Okay, so this is a 30-something female, G6, P6, and had a C-section. And this is after the C-section, there was ongoing bleeding. And so this is the ultrasound that followed that episode of bleeding. I think maybe after this, they might have gone in and tried to investigate with hysteroscopes and whatnot.
Wait, Steve, I need some crucial imaging on this, which is the color and Doppler imaging,
Yeah,
because we're wondering about retained products, or is
right.
this just blood? Okay, wait. So I see flow in there and it looks maybe like true flow. I want some Doppler on that. And I'm making this point also for the residents, like you can't just put color on stuff because you can always get artifacts. So you always want to put like a true Doppler on it and see if it's arterial or venous.
I
Do you have
don't
any?
know if I have like a pulse Doppler on this, just color.
Rookie move, man.
Maybe it was a fail.
But anyway, that is something I like gallbladder when we look at sludge versus a mass, or like endometrial hematoma versus retained products. You always want to put pulse Doppler in there and see if it's true flow, or like if it could be. This looks true. It doesn't look like.
It was believed to have internal vascularity
Okay.
based
So
on
now we're concerned about retained products of conception, perhaps.
right.
Yeah.
So
And the other consideration that we think about is like an AVM, but those are super vascular. It's
And they're based more in the myometrium
right.
versus being in the endometrium.
Excellent. So they tried to solve this, but couldn't solve it with a procedure following this. And so we got asked to do an MRI, which I don't think we do these very often. So that's why I'm showing it, because it was unusual for me. Let me resize the box a little bit. There's some motion on this, but you can see here that's not that great. This is T1. This is T2 fat sat. Here's the stuff in the endometrial canal. This is some diffusion. High B value here, I think. ADC. There's T2 again in a coronal. And then here's another T2,
I do
another
see some like flow voids
a T2,
on
yeah.
that axial T2. I saw some flow
And
voids.
sorry,
then,
can you go back to the T2 sagittal?
yeah, it's kind of blurry from motion, looks like.
Oh yeah. But I don't think it's an AVM.
Here's pre, and then post contrast.
They're
Sorry
still
about
like really enhancing in the middle of the endometrium.
Yeah,
So I guess that's part of the placenta.
yeah.
And
Yeah, I
So
think it's retained products, RPOs, yeah.
I actually read this, yeah, and I read this as suspected retained products with a vascular stalk, because it looked like it was connected to the back wall of the endometrium, and quite vascular, even compared to myometrium. It's more vascular than myometrium on this. And then there's some fluid or non-enhancing stuff sort of in between in the endometrial canal, but not this thing that goes from looking like this pre-contrast to this post-contrast. So enhancing. I don't know if
very pretty. And Victoria says beautiful.
we don't have subtractions. I think there's maybe these are subtractions. So here's subtractions, and then Sag again with the artifact a little bit, but you can tell that there's this enhancing mass in there. So I think they went after it again, but failed. They were encountering a lot of bleeding and couldn't really find the base of this thing to remove it. And so after that, the patient went to IR and got a uterine artery embo. Whoops. And subsequent to that, the bleeding stopped, and I think they passed some stuff, and the pathology was some retained product that was necrotic by the time it was all said and done.
Wow, it's very interesting because you would think with a C-section they'd be able to see everything, but I can see also how, like, you know, a small piece of the placenta, because the placenta is really big.
Yeah.
Small, like, even though it looks big in this, you know, your retained thing here, it's actually small compared to how big the placenta is. So I could see how they could miss a little part of it as they're pulling it out, I guess.
Right. And I don't know if you guys do IR at all, but if there's details you're interested in, I could probably find them in the report. It looks like it was particle embolization.
No, that makes sense. At least to just
Embol
temporarily stop the bleeding.
microspheres to temporize things, right?
Yeah.
And there was a little blush in here that got better with right after the microspheres. That vessel and the stuff that was in the center here is not as enhanced. Whoops. I'm not sure what that is. That's too.
I think we can stop.
All right.
Thank you.
That's my case.
Awesome.
Okay. This is the patient who had pelvic pain, and we did a history of endometriosis, and we did an NMR, abdomen and pelvis. And the pelvis looks pretty negative for deep endo, not really much. The interesting part is the abdomen.
There's some little bright foci along the liver.
Yes. Here's your FAST T2.
I just showed a case like this at our case conference like a month ago.
Yeah.
Yeah. And it was exactly like, well, mine had endometriosis in the pelvis,
Yeah.
but then spread along the liver dome.
Yes. So here on the T2 fat sat, you see these little T2 bright areas. You don't always see this T1 bright. I mean, this is what you want to see, but you don't always see it. And I think that the T2 facet is more sensitive for diaphragmatic endo. And this is what you see. You see little T2 hyperintense spots along the capsule, like here and like that. So this is diaphragmatic endo, and this is the operative imaging.
Wow.
Wow, those
Bunch
pictures
of
are
mini
so cool.
seromas.
Yeah.
Wow. So, and as I explained in the case that I showed, like the peritoneal cycle goes up along towards the right side and then between the liver and the diaphragm. And then there's fenestrations in the diaphragm, and that's how the endometriosis gets through to the lungs that causes catamenial pneumothorax.
Oh, I didn't know there was fenestrations. That makes
Yeah.
sense.
Yeah, exactly. It's not hematogenous spread of endometriosis to the lungs. It's basically because of the peritoneal cycle, you get it, you know, it pushes it in that direction. And then also there's not ligaments that protect the dome of the liver. So that's why METs and also endometriosis goes up there. And then it gets into the lung base because of the fenestrations.
When I've seen diaphragmatic endo, it's always been on the right side, right? Because that's the cycle of the peritoneal cycle, right? It's
And also
clockwise,
the
and
left
then it
side.
always.
Yeah, also the left side is protected by, I think it's the splenorenal ligament. There's some ligaments up there that protect the left diaphragm.
So I think diaphragmatic endo is hard to see. And you have to really be looking carefully. And one of the things that we've been talking about is to try to optimize the sequences. And like my colleague, Mark Stugi, suggested we limit the field of view, right? And I think that totally makes sense. Right now we get these large field of view, but if we, narrowed it down, like to be more focused on the right diaphragm, I think that would really like improve our diagnostic capability.
But it's also rare. So I don't know, you're going to do small field of view of every diaphragm, like, I think it's also just looking there, like
Not
a lot
every,
of people...
like this one came in with high level of suspicion for diaphragmatic endo. So we have a protocol for endo for the diaphragm.
Oh, wow.
Yeah,
That's
we
amazing.
did that. This is the protocol that I'm sharing with you, is because the patient had respiratory symptoms.
Very cool.
Yeah.
I also think like people just don't look at that area a lot. So even METs will follow the peritoneal cycle and end up there. So if you look at the coronal, for example, you might see like, like pseudomyxoma peritonei, you'll see like deposits right there under the right hemidiaphragm that you don't see well on axial, but you might see it better on coronal. And especially if you're like looking in that area, So I feel like it's a good pitfall area.
Don't
Victoria,
feel like corona is very helpful.
yeah.
I don't think corona is very helpful, but yeah, I guess if it's.
Well, I think on CT, like what I'm
Oh,
talking
you mean
about
on
is
CT?
like
Sorry.
on
Okay.
like pseudomyxoma mets and stuff on the coronal, I think it's helpful, but here, yeah, it's jumping around. So
Yeah.
Because of the peritoneal flow between the diaphragm and the liver is another place you see the peritoneal bodies, the detached epiploic appendages. They wedge in that space a lot.
exactly, the
They get
pseudo
incorporated into the capsule. It could be like a pseudolipoma of glycine capsule.
Yep. Okay, Victoria had to step out. Okay, so actually I want the residents to participate. Focus on the pylorus and duodenal region. I'll show you, this is the axial, and the history was duodenal neuroendocrine tumor. What do you guys think? I can show you the coronal if you want.
Okay.
There's a measurement. I'm taking off. Okay, but I'm going to go back to the axial. I want to ask you a couple of things.
Okay.
One, what do you think this is?
So again, near the gastric pylorus, so we're right at the proximal duo.
Yeah. So this is the pylorus. This is the pyloric channel.
Yep.
And I point this out because when one of my trainees got the history of duodenal neuroendocrine tumor, they were like, okay, 4-centimeter circumferential apple core thickening of the duodenum compatible with known neuroendocrine tumor. So I guess one point is that like the pylorus can be really thick, especially when contracted. And this is kind of like the antropyloric channel. The pylorus is like the muscle over here. But just to like, normally in the GI tract, if we see something apple core, we think about a malignancy, but just know like this region can just, kind of contract. And then duodenal neuroendocrine tumor, this is the duodenal bulb. It's this triangular kind of arrow-shaped area here. And I'll just point out that there is this enhancing soft tissue just caudal to the bulb here. And on the coronal, that was what we were measuring. So what do you think about that?
Well,
this.
so
Just history is duodenal neuroendocrine tumor.
Okay, history of neuroendocrine tumor. So I'll just be blunt with you guys. You have 2 R1s right now. But so a I'm not sure if we have a non-con, but hyper attenuating mass in the proximal duo. We are relatively close to the head of the pancreas. But
yep.
Things that I would be worried about is any type of neuroendocrine stuff. You think about like, I want to know what like clinical manifestations, like any like history of things that could lead me to like insulinoma, gastrinoma, stuff like that.
Awesome. Okay. So those are pancreatic neuroendocrine tumors. And then in the duo, you can also get gastrinomas because we're in the gastrinoma triangle. I'm curious, Nelly, what do you think about?
I mean, I would put GIST in there too.
Okay.
Steve, what else?
I'll tell you, I don't have the final answer on this, but I have a theory.
Pancreas.
Sometimes you can get ectopic
pancreas.
Yeah.
Oh, like an annular.
I was clicking my unmute while you said it.
So it's just, I don't have proof because I've convinced them so much that it's ectopic pancreas that nobody's taking it out. But you will notice that this stuff, okay, so when I heard, okay,
Can
duodenal
you go back to the
neuroendocrine tumor.
axial? Yeah, okay, there you go. Sorry.
So when I heard duodenal neuroendocrine tumor, anytime you hear that, usually, and then we went back to the EGD report, the neuroendocrine tumor was a tiny incidental 4 millimeter polyp in the duodenal bulb that once resected came back neuroendocrine tumor. Okay. So it was a tiny little polyp. So it's not this thickening of the pylorus and it's not this mass, but even a tiny little duodenal polyp can cause a nodal metastasis. So as soon as I saw this, I was like, oh, cool. This is like a nodal metastasis from this duodenal polyp. And like, you know, you should, whenever you see a node in this area, you should go back and look for a duodenal neuroendocrine tumor, blah, blah, blah. But the more we looked at it, we're like, is this truly a node? Like, why is it so affiliated with the wall of the duodenum? And why does it look exactly like the pancreas? And it has like
That's a good
vessels
node. I
coming
like
from
it
the
for
pancreas.
ectopic pancreas.
Yeah. Okay. So then we're like, somebody said we should get an MRI, but we already had an MRI. So I'm going to show you the MRI now. So for pancreas, two of the main sequences or helpful sequences we look at. One is the T1 pre-contrast because the pancreas is really bright because it has protein and manganese. And we can see the pink.
Oh, I didn't know it had manganese.
Yep. That's what causes it to be T1 bright. And if
Oh.
you see, my tissue over there is bright, just like the pancreas,
Now
unlike anything else here, right? So that definitely goes for ectopic pancreatic tissue. And then the other one that would go against being a lymph node is lymph nodes are really bright on diffusion. So even a normal lymph node, like you can see all these tiny dots here in the retroperitoneum, they're really bright. Every lymph node lights up super bright. And my little guy, where is he? He's right over here, not bright, just like the pancreas. So I don't think it's a neuroendocrine lymph node. I think it's ectopic pancreas, just like Nelly and Steve thought too. So it's just a really cute case. I have seen a couple of dramatic ectopic pancreas cases, like one where there was an entirely second pancreas coming off the jejunum here. I'll try to pull that up actually while we're waiting. But anyway, just a really
Cases they show in the unknown film panel are ectopic pancreatitis.
Yeah. Yeah. So I guess just to round out the conversation, usually ectopic pancreas is seen in the antrum of the stomach. That's the most common ectopic location. It can cause pancreatitis, but it's often not diagnosed prospectively. Another place you can see it is in a Meckel's diverticulum. So Meckel's diverticulum can have ectopic gastric tissue, which is why it takes up pertechnetate. And then it can also have ectopic pancreatic tissue. And then other places like, this is sort of in like the annular pancreas spectrum because it's like really close by, but not fused. One other interesting finding is that ectopic pancreas can have ducts and they can even have IPMNs. So yeah, they can develop all the same diseases and they're more prone to getting pancreatitis. Yeah, that was that. Okay, Victoria is back.
This patient came in with abdominal pain. Actually, specifically right anterior lateral abdominal pain.
Wait, there's something in the gallbladder.
Yes, tell me.
Yes.
No priors.
Oh, okay.
There's some
the ED. This is the weirdest pancreas I've seen in a long time. There's like a weirdest gallbladder I've seen in a long time. Yeah. So there's a solid enhancing mass of the gallbladder fundus, but there's also like this linear thing I don't know if that's enhancing or just like a cast inside the gallbladder.
Maybe it's like a plate-like calculus.
Yeah, plate-like stone. But Nelly, I want to say one thing about the gallbladder fundus mass.
Yes.
I have seen a paraganglioma of the gallbladder. So that's coming to light. It does not look like a normal gallbladder cancer.
Yeah, those are ugly. This is not ugly.
This almost looks a little bit like liver tissue, but
here it is.
Don't even tell me it's ectopic pancreas. No, it's not fluffy enough. I don't see any ducts.
Is there a spleen?
Yes, I believe so.
Making
Sorry,
sure we're not looking at like ectopic spleen.
this means right there.
Spleen's fine.
Yeah.
Wait, show us the MR.
MR. Yes, so we got an MR. And I need the drum roll. So this is that luminal linear thing right there. That's your gallbladder finding. And here's our T1. And then
Just like
here's your
sludge?
subtraction. Oh, that's a misregistration artifact.
Yeah,
Here,
so
let
it's
me
just
give you.
sludge.
Not enhancing.
It's sludge in like a gallbladder
Yeah.
fold.
Yeah.
Yes.
There's like
Yes.
a phrygian cap that's folded over or something.
Right there. Yes. Right there.
Then it's like species and sludge inside.
Yes, and that linear thing in the it wasn't enhancing either. It's just tumefactive sludge or something.
Or a stone. Like on the T2, it looked like a long T2 dark thing,
very
right?
dark.
Isn't it like a plate-like stone?
Yeah.
Perhaps, yeah,
Cast.
maybe. Yeah, right there.
Ooh.
So it's just a fake out.
On MRI, bile that has a gradient to it isn't necessarily sludge. Because if you just take bile and stick it in a beaker and then have it sit for a while and put it in an MRI, it can form a gradient like that, even though it's not like semi-solid.
Yeah, we call it hyperconcentrated bile versus sludge.
Yeah.
This is a great point for the residents. So anything that looks solid, unless you have a pre-contrast, we don't know, could be just a debris or sludge or, on ultrasound, if you were to image this, that's where you put the color and the Doppler on. And then on MRI, we get these wonderful subtraction images. We can see that there's no true enhancement. So it's just sludge, which is a controversial term, I would say. Do you guys even report sludge? So 80% of sludge is transient. So if you were fasting, you could even have sludge in your gallbladder. So it's a little bit like, should we even report it? Does it matter? But I would say if it looks tumefactive, if it's on multiple exams, in this case, it's probably hyperconcentrated or sludge-like because of that fold. So it's getting trapped there. But, oh, nice. You have an ultrasound.
Yep, this is our fundal sludge ball.
Okay, on that ultrasound, wouldn't you have called that a
there's
stone given the
yes,
shadow?
because it's so exactly. There's and then this is that luminal finding.
Also lots of shadowing.
Yeah.
But I think worth exploring because it's different. Okay, Victoria.
Kind of cases. This is patient without any prior history of anything. Should I let the residents kind of take a stab at it or just describe it?
Let's just describe it. I feel bad because the residents told me there's 2 R1s.
Okay.
And they're doing great.
Right, so
and we were all there.
Appreciate
We've all been there.
all right. So
liver morphology.
So the patient has absolutely no prior history of anything. Liver looks normal, right? We have
given the avid arterial enhancement and ISO intensity on delayed, my first thought was FNH.
Yes, I was thinking the same thing. I think though, and I still think this is FNH, but I mean, how do you not exclude like an adenoma?
Guys, look, this is enhancing less than parenchyma. This is washout. No,
but on the further delayed, is it washing out or no?
I would like an MRI to
okay.
got it. About what we're looking at.
There, see. Also, look, it has cut. This is not the typical FNH morphology where the kind of the septi radiate from the center. This is the mosaic. This is
fibrolamellar scar doesn't enhance centrally, and the FNH does.
Yeah. This is an older lady. She's 70. This was resected. This is moderately differentiated HCC. Okay.
Whoa. Wait.
Also,
I'm
another
sorry.
thing. Oh, wait, another
Patient
thing.
had
Wait a
cirrhosis
second.
or
Another thing. Nope. Patient
Or
has. You can have HCCs in patients who don't have cirrhosis.
Yep.
But also another thing that I would be cautious about thinking about FNH here. Look at how dark it is on pre-contrast. That's just
Yeah,
not
that
good.
does go for it.
And there are areas that look little necrosis, and then there are some areas of washout. So
I think
right,
this is
so
a great
that's-
case for liver windows
did
too.
it-
So Victoria, put them back on your normal, like the windows you had at the beginning.
but this one's still lower.
No, I know. But
Okay,
and then
yep.
put the pre on the normal window.
Oh, yes, it is normal window.
Okay. Yeah,
Right.
I see.
All
Yeah, I
right.
see your point. It's definitely like lower and there's some washout. But I feel like there's a lot of retention on the delayed, but point taken. I think this is a good.
But I mean, they didn't. I mean, did they biopsy or get an MR or something before taking the patient for resection, or was it they just said this is HCC?
They said this is an old case. This is from 2000. I don't know, from 2008. This was read as consistent with malignancy and gave the differential, which is how again in a patient without Hep B or cirrhosis, this is differential and goes on. All right, so okay, this is another. And this one actually has an MR. Same history. Patient has new history of parenchymal liver disease. Now, if I do this, do you see 4 images or 2 images?
2.
Okay, so so you can see the same, very similar appearance, right? Kind of lowish on, here, I'll zoom in, kind of lowish on pre, very avidly enhancing an arterial phase, and then very similar appearance, kind of heterogeneous with some areas that wash out. And now
On that
you're
arterial phase, I just want to point out there's a lot more like vessels going into that one. Right. It seems like there's like these hypertrophied vessels going in and a lot more heterogeneity. But anyway, go ahead.
Okay. This one, MR, right? Beautiful enhancement, beautiful washout, T2 hyper, hepatobiliary phase hyper, again, clear, normal liver. Any thoughts of what difference that means?
Wait, can you show me the in and out?
All right, let me stop sharing for 1 sec, or stop recording. I just don't want to. Sometimes it's on the diffusion, right? So there's clearly diffusion restriction, and I'll show you in and out of phase. And here's in and out of phase. Any thoughts?
With a dropout, right?
Nope.
Not really.
Oh, maybe I was just.
No, you have to be very careful. But look, it's kind of
Yeah. Now it looks like so. Yeah.
Thing.
I would add biphenotypic subtype into this.
This is a healthy patient. So it looks very, it pretty much looks identical. So this was
Are you showing the T2 again?
I was asking for the in and out is because I was thinking angiomyolipoma with all the vessels, but I still think it's concerning.
Yeah, I don't like any of this one or the prior because the FNHs and adenomas tend to be less busy.
Yeah, you do not want to call this an FNH. This is too aggressive. Like when you see vessels like this, that's
an FNH doesn't restrict like that. Yeah.
No. And then I showed you the hepatobiliary phase. It was very dark.
Yes, hypo. Yeah.
All right. Anyway,
all
so this
concerned.
was resected.
Malignancy.
So this was resected, and this is ready. PEComa.
What?
This was a PEComa. This was a PEComa, which is perivascular endothelial. Help me out of here. Hold on, let me just. I'll bring up the
sugar tumor.
There. This was this. Perivascular epithelial cell neoplasm.
I don't think we can make that diagnosis prospectively.
No, you can't. No. I am showing you these 3 cases with a very with intentional intent. How about that?
Yep.
All right, the third companion.
Is PEComa, are they malignant? They're not, right? Are they?
They can be.
Oh, yes. So the standard would still be to resection, even if we had a diagnosis with biopsy prior.
Correct.
Got it.
Mm-hmm. All right. So now the final companion case is this one. Again, the same. They're all women. They're all about the same age in their 60s. Healthy livers. Okay. Okay. Very similar. A dark T1 hypointense mass. Hypointense on hepatobiliary phase. Now here I don't have a CT. I only have an MR. And I mean, this was the original CT where she was noted to have the mass. There's the arterial phase, right? Again, very avidly enhancing. There's the
The
portal
T2.
venous phase. I'll show you in 1 second.
By the way, there's like a
Here's
second
the-
FNH. There's an FNH in front of the cava, a second lesion.
That's correct. But you can see that it looks very different from this lesion. Okay, and here's the T2. And this is quite an old case, so this is as good of a
Solitary fibrous tumor.
Yeah. This is not really the.
Wait, did you say yes?
No.
Oh, that's all.
This
Oh, how do you know that, Aarti?
No, it's not.
It's
not.
not.
Oh,
Again, no. I'm saying no. You can see.
Oh,
that they're
okay.
Also,
Ooh,
I mean,
this
I
could
would
be
add
a
sarcoma
sarcoma.
in here, angiosarc. Like, that's that I would add.
but I want to point out the same thing, that it has a similar enhancement pattern, markedly, heterogeneous arterial phase hyperenhancement, and then some areas of washouts. Okay, so great. So, but if there any part of the liver that the lesion demonstrates washout, you say it's washing out. So it doesn't matter that it's a little bit or a lot. Anyway, so this was resected, and this is lipid poor AML. Okay, so I showed you 3 lesions, which is very similar in appearance. And when the patients have healthy livers, we just provide differential diagnosis because preoperative diagnosis may not be possible, and we really cannot diagnose even HCC without PATH in patients who have healthy livers. And this is why, because these patients can also have adenomas that enhance very similarly. They can have neuroendocrine tumors, METs, which enhance very similarly. So in the patients with healthy livers, this pattern of enhancement, we have arterial phase hyperenhancement washout. We have to get a biopsy for diagnosis. So
I'm kind of surprised that they all went to surgery without biopsy beforehand.
Memorial.
Interesting.
If we think that there's a substantial chance of malignancy, then they just take it out.
Yeah, I would say they probably would have all gotten biopsied here, to be honest. Because I've seen FNHs
Here
that are
too.
massive. I've seen FNHs that are massive and also have atypical features. So some FNHs have a little bit of washout, some can have fat, some can have heterogeneity. Right. So we know that FNHs can be atypical, and I wouldn't want to lose like half my liver because of an FNH. So I still think, I don't know. I think that a biopsy would not be that invasive.
you wouldn't consider FNH here, right?
No.
And you wouldn't consider FNH
not,
in that in the PEComa. You wouldn't also consider FNH because it was also hypointense on hepatobiliary phase. I don't have for HCC case. There's only CT, so there's just one for resection. Those are not my cases. These are I've collected these cases as a follow-up. So I don't know what went in, what conversations went in terms of biopsy versus resections. I've had these conversations where, let's biopsy it first. And then sometimes the idea is that, if it's, it's going to be if it's an adenoma, it's going to be resected. If it's an HCC, it's going to be it's a solitary thing. It will be so. I've had situations where the surgeon's it won't we'll have to resect it no matter what, so they just resect it. So I don't know if this was the conversation here. I don't, and it's possible that there were paths, but it's also possible that there was biopsy outside. On outside incision that we don't have access to, so it's possible that these were biopsied before they went for PATH somewhere else. That's a possibility. I just don't know.
One
But
additional
us, we just
thing
have
is,
the,
now there's a lot of immunotherapy for HCC, so that's one additional reason to potentially biopsy.
Here's
yeah,
a,
but if you consider resection, that's, you know, that's, again, that won't change mention,
From a-
right? Like if you think it's a solitary, like in the case of HCC, right? As that first HCC I showed you, it's a solitary lesion with preserved liver function. The best bet is to resect it, like instead of immunotherapy.
Right. But like you just showed, it could be a lipid poor AML. So why would you resect it? But anyway, okay, we will.
But it was very big.
if
Okay.
it's epithelioid subtype of AML in the liver, those are considered pre-malignant.
Should I continue or we're going to switch out?
This patient has pelvic pain. Okay, that's your, and then the T1 is, so there's an endometrioma on the right, this T1 hyperintense finding. I want you to focus on this.
That the cervix? Like, are they? No.
Here's your Sag.
Were those T1 bright things corresponding to those like Nimbothia and Cis? No.
You're talking about the right, this thing? Which one?
No. The you said to focus on the T1
Oh,
bright
this one.
stuff.
This stuff. Yeah, this stuff here.
Oh, I see.
So it's at the fundus. It's pretty up high right there.
Parts of it look like it could be a leiomyoma, but then it's got these internal complexities and hemorrhage.
And here's a post-con.
Wait, is this your
So-
cavitated uterine mass? Which is like endometriosis.
My second cavitated uterine mass. So yes. So this is a accessory cavitated uterine mass. It's spectrum of Müllerian anomalies, kind of a newly described variant. And what you have is kind of histologically, you have endometrium centrally. This is why it's bright. This is kind of blood, like kind of different age blood clots, and that's why you see kind of this differences in signal. And then myometrium. So endometrium, and then you have myometrial outer layer. It is like a cavitated mass. It's round. And histologically, this represents myometrium and endometrium, but it doesn't communicate with the endometrium here, with the normal uterus. So patients often have cyclic pain. These are often treated surgically with like resection. So yeah, this is accessory cavitated uterine mass, ACUM. The patient does have concomitant adenomyosis. There's little T2 hyperintense findings there. But it's different from adeno because adeno is kind of more diffuse. I mean, I guess you can have focal adenomyoma, but they don't really have the cystic cavitation from the endometrium. And fibroids are more kind of homogeneous and ball-like. I mean, you can have degenerating fibroid kind of areas of hypoenhancement, but it's not really cavitating. It's not central. It's not rounded central cavitation.
And this is thought to be a Müllerian abnormality, like
Yes.
a genital thing. Got it.
Yes.
Okay. What is this? So we can see the common femoral artery and vein here and here, but there's some asymmetry in that on this left side, there is the soft tissue. What is that? Is it a hematoma? Is it a mass? Is it a lymph node?
Do you have the coronal?
Yep.
Not a lymph node. It's like a hypertrophic scar or maybe a pseudoaneurysm.
There it is in the coronal. Go back to the axial for a sec. So pseudoaneurysm, hypertrophic scar.
Or is it a detached muscle?
Yeah,
It's contiguous with
Yeah.
so you see
The
up
anterior
here.
rectus, right there, like
Okay, look. So up here, there's asymmetry.
it's like a. Do
And-
they have a flap or like?
And
some
down
kind of-
here, they look symmetric. So what is this?
was that on purpose?
Yes. So this is a Gracilis flap. This patient had a common femoral artery pseudoaneurysm that got infected. They had surgery. You can see there's all these surgical clips. And after, reconstructing the artery and everything because of the infection and inflammation, they did a Gracilis flap. And so down here, it's attached to the Gracilis. So I just wanted to talk for a few seconds about the Gracilis flap. This is called a workhorse flap because it's used in many different parts of your body. It can be a free flap where they completely disconnect the gracilis muscle and use it, for example, like to make a face flap in your, like to reconstruct facial muscles. They can use it for, other parts of the body, but they can also do a connected flap where basically part of it is normally connected and they just flip part of it up. They disconnect it and they flip part of it up and over to protect these vessels and promote healing. So this is just a Gracilis flap that was used in this situation. Don't confuse it for like a hematoma or anything else. It's kind of cool. They try to keep the pedicle, like the vessel and the neuromuscular pedicle. When they have it either connected or even when they disconnect it, they'll try to keep that pedicle alive. So.
So
Patient had a palpable testicular like abnormality. So got an ultrasound, and on ultrasound we saw this hypoechoic nodule. It wasn't enhanced. There was no flow into it. So we recommended an MR, and this is what we saw in MR. So there's more than just one. There's actually multiple bilateral T2 hypointense lesions in the testicles. And this is we have post-con sequence. So let me see now. There's here is 30 seconds fat sat. Not really like convincing enhancement. And then we have, here's 5 minutes. Pretty homogeneous. Here's a subtraction. Any thoughts? Here's your axial.
So they're mostly standing out on the ultrasound and the T2.
Yes. Here's your T2.
On the T2, they almost look like granulomas or scars or something. Like
right there, there's your T2. Very kind of low signal.
The fact that they don't enhance differently than the rest of the scrotum, or testicle, makes me reassured that they're not malignancy. Did they have mumps, TB?
No.
They don't look like adrenal rests.
And it was just, like I said, incidental. Like the patient felt like a palpable something.
I feel like they're kind of like scar granulomas or something. I don't know.
Yeah. So, well, specifically Cookie. So we think this is a case of testicular cell, Leydig cell hyperplasia. And this is one of the case report from AGR. And it kind of corresponds to our imaging findings. It was hypoechoic, and it has low T2 hypointense signal. This case here in the journal has mild enhancement, but they don't always have enhancement. And what I learned is latex cell hyperplasia, that's how they look like. They're usually bilateral, multiple T2 hypointense lesions that may have minimal or mild contrast enhancement, and they're relatively small.
And is there a
So
clinical consequence?
I don't think so. I think these are benign.
Wait, it says
that-
because they produce
ahead.
androgens, increased luteinizing hormone can result in hyperplasia. Okay.
I think there was a case of this on a non-neoplastic testicular lesion paper that I reviewed.
It says medical treatment may be feasible.
Hmm.
If they're hormonally active.
Yeah, it seems like it's part of the pituitary, like there's some hormone imbalance that arises from them.
And then I see there's primary and secondary versions. So primary is from a mutation. And then secondary is idiopathic.
Cool.
Check this out. This is the stomach, right? And you can see that there's posterior gastric wall thickening and kind of like this little crater, right, with like little overhanging edges. You can see it on earlier
Beautiful.
contrast, and this is,
MRIs
isn't that cute?
Yeah.
Huh?
So it looks like instead of a benign ulcer, it looks more like a malignant ulcer with like an ulcer within a mass.
See, I think it's a benign ulcer because you can see that the mucosa comes out. So I don't know. I don't have the past, but it's new from August, and August it was normal. So I think this is, and sometimes you can see that. I can bring up like next time we have like edema, like from the ulcer, it makes the wall thicken. But then when you see this very nice sharp edge of the overhanging edge, that sort of goes, and you can see here, this is just kind of very thin enhancement. There's, you know, so I think
I can see that. It looks very, the
benign.
mucosa itself
Right.
looks really smooth.
Right. So I think that's just going to be a benign ulcer, but it's very cute. So I said that they need to correlate with you know, with symptoms and stuff. And this is final case, very quick one, not a diagnostic, not an eye test. You can see like a pancreatic mass, no pancreatic ductal dilatation, very heterogeneous. Aarti, any thoughts? You said this diagnosis.
SPEN versus neuroendocrine tumor, cystic neuroendocrine. I'm favoring
So
SPEN.
this ended up being solitary fibrous tumor.
Oh my God, this thing, this thing is like out
Isn't
to
that
get.
cool? I know, but like, I mean, the thing is like this is the case where, you know, you provide a differential diagnosis and you know, in this case, like there's no way you can even suggest this is a pre-op diagnosis, but.
Yeah. By the way, do you have an
pretty,
MR, just
pretty-
out of curiosity?
No, well, let's see. Do I have an MR? I think I don't.
Okay. This is a postmenopausal patient who has this ovary. It's measuring 6 centimeters, cystic, septations, little echogenic foci. What would you say about this?
MRI.
ORAD, not okay.
Okay. So we got an MRI. And here it is. There it is. I'll show you several, let's see, high res. So there it is. Very T2 bright, very weird blobby appearance. Some septations, pre-contrast, not a lot of T1 hyperintensity. It's not an endometrioma.
So like a myxoid or a mucin thing.
Got
Some
some
weird septa.
lesions.
Huh?
Right. Doesn't
Septations, exactly. Enhancing nodular septations.
that's a
Literally, our report said ORAD's 4, we put it in the ORADS algorithm. We said ORADS 4, surgical onc or gyne-onc recommended. Oh no, actually we said ORADS 5. Sorry, ORADS 5. So they resected this and it came back struma ovariae. So just a couple of points about struma ovariae. It's when you have thyroid tissue in your ovary. It is a type of dermoid that is a pure dermoid. So dermoids, mature or immature teratomas, have all 3 layers: ectoderm, mesoderm, endoderm. So they can make skin, they can make bone, they can make hair, and they can make lots of different parts of your body. But struma ovariae is when you have a dermoid that is only one component, which is thyroid tissue. And actually, if you go online and like look at struma ovariae, it actually kind of looks like this. So I don't know. In retrospect, I think it's still a surgical lesion. I have no regrets, but it does look very different than other epithelial neoplasms that we normally see. Like, you know, it just looked different, right? It doesn't look like a rounded cystic thing with septa that had these weird nodules. And also in retrospect, there's something called struma pearls. I'm just going to pull the ultrasound back up. And those are little echogenic foci within the lesion that are sort of like colloid. So anyway, these little like echogenic nodules could be struma pearls. This is all in retrospect. I still think this is a surgical lesion. Just wanted to show you this is a path-proven case of thyroid tissue in your ovary. And another thing you can do is check to see if the patient is hyperthyroid. This patient was not, but if they're hormonally active, they could be hyperthyroid. So yeah, just looks a little different than a normal epithelial neoplasm like serous or mucinous of the ovary, but I think it's a subtle point, and I think it's surgical either way. So
Great case.
okay,